All right. I'm Sagar Kansara. I'm a head and neck surgical oncologist in microvascular reconstruction with the LSU Department of Otolaryngology. My practice is in Baton Rouge, as Dr. Walvikar mentioned. I have no disclosures. Um, my, I'm going to hopefully in the next 40 minutes discuss the immunology of head and neck cancer. It's patently absurd to try to cover that in 40 minutes or 30 minutes, but we'll try to distill it into the high notes so that we can at least come away with some understanding, foundational understanding of what drives tumorigenesis in head and neck cancer. And my goal, hopefully, is to leave you with more questions than you came with, and less answers than you came with. So, and this is really what drives our understanding of head and neck cancer. It's well-intentioned people with good ideas. And so, the other goal today also is hopefully to ask some pretty existential questions about head and neck cancer. So, for example, what is cancer? A lot of my practice is, taking out tongues and larynx with cancer in them, but even when we try to reconstruct these organs, the innate organ is infinitely more functional. Even a cancer-laden organ is infinitely more functional than anything we transplant from the forearm or the thigh, which is a big part of my practice too, is reconstructive surgery. Is tumor is tumor just normal tissue that's having a bad day, so to speak, or is it just some tissue that needs some help? And you'll see what I mean. It's possible that this process might be reversible, and that's really a fundamental question. And so these are some of the objectives today, and hopefully we can make some headway in that. So first, some clinical vignettes. So on the left, you'll see a 59-year-old man. He has a long smoking history. He's got worsening right mandibular swelling and pain, which he attributes to dental extractions, but almost certainly is not related to that. He's fairly sick. He has AFib. He's on Eliquis. And on physical exam, he's got a very large oral cavity mass. On the other hand, you've got a 56-year-old Caucasian gentleman. He presents with just a neck mass that he found while shaving. And otherwise is very healthy and doesn't smoke. And really this dichotomous patient presentation has really come to really give us a lot of insights into head and neck cancer immunology. So just some representative scans. On the screen left, you'll see a massive erosive mass that erodes the mandible there. And then on screen right, you see just a small tonsil cancer that's FDG avid and one FDG avid lymph node. So fundamentally different pathologies here, but both are squamous cell carcinoma. And so one is smoking mediated, the other is virally mediated. As Dr. Mwala mentioned earlier, there's been an epidemic of human papillomavirus associated oropharyngeal squamous cell carcinoma. So over the next couple of slides, we'll try to understand what the difference is. So this is really a monumental time in history for head and neck cancer. The epidemiology of the disease has changed right before our eyes. So as you can see in the graph, each subsite is coded by a different color, and the y-axis is each subsite's proportion of all head and neck cancers. And you can see the oropharynx is blue, that's steadily increasing. The others are holding steady or slightly decreasing. You can see larynx cancer slightly decreased, probably with as we learn to come to understand that smoking has such deleterious effects on our health. And then you look at lip, oral cavity, larynx, they've all decreased in comparison to oropharynx. And so in other words, we have a disease that's really changing before our eyes. And when you extrapolate this trend to 2030, you see that oropharyngeal cancer will far surpass all the other subsites within a decade. So why does this matter? So we all know that HPV-related oropharynx cancer is a very different phenotype, as we've discussed. This was a landmark article in the New England Journal by Eng and colleagues from 2010. They characterized oropharynx cancer as either low, intermediate, or high-risk disease, and they looked at that based on HPV status and smoking. So you'll see the patients that do the best, those are the blue lines. Those are the patients that have HPV-associated disease and don't smoke. You look at the intermediate risk, that's that's HPV positive patients that have a less than 10 pack year smoking history. And then the highest risk, or the most poorly functioning and cancer-related outcomes, are related to high smoking and HPV negative disease. So as you can see, there's a clear overall survival difference between these subgroups. But the problem is that even in spite of our understanding of this, or sort of a fundamental understanding of HPV, we still are really bad at treating it, and that's a problem. So, and you can see that in this graph. This is a graph of 5-year survival for each subsite as a function of time. And you can see we've gotten better at managing oropharynx cancer, but a lot of that is due to the epidemiology of disease, and that's related to HPV. And also, as we'll see with Dr. Brown soon, intensity modulated radiation therapy, that's IMRT, has really helped us to sort of focus radiation to a certain area and spare critical structures. But then you look at oral cavity, larynx, and hypopharynx, we still suck at it. And so we're basically just as bad at treating this cancer as we were 50 years ago, and that's a fundamental problem. And so if we are going to be better at treating this, we need a better understanding of head and neck cancer. And so this is, if you come away with nothing else, this is what you really need to know about fundamental pathogenesis of head and neck cancer. And we'll come back to this theme often. But a lymphocyte-rich tumor microenvironment, that's a tumor microenvironment in which there's a ton of innate immunity. That's what you see often in HPV cancer. In this setting, you'll have a high immune signature. You'll have increased cytotoxic T cell activity and essentially efficient anti-tumor immunity. But when you look at the bottom part, that part C, the molecular smoking signature, you'll see these patients often are immunosuppressed. And this is in part the reason that HPV negative cancers do much more poorly. And so this was a study from 2016 where the authors performed immunohistochemistry as well as RNA sequencing on 40 different tumors, both HPV positive and negative tumors. You can see the actual number of lymphocytes was not significantly different. There was a trend toward higher lymphocyte expression in the HPV group, but they did find that there was a differential expression of B and T cell markers in the HPV positive group. And it's kind of a busy slide here, but if you just take away that, so at the top there, you see the black is all the HPV positive tumors, the brown is all the HPV negative tumors, and the red is basically high expression of certain B cell and T cell markers. You can see all the patients that are in black there had basically trend towards higher immune signature, whereas the HPV negative patients, they all trend towards a lower expression of this immune signature. Again, this is replicated with T cells. So if you look at CD4 and CD8 T cells, you'll see that HPV positive patients have a much higher signature of T cell activity. And why does this matter clinically? So you'll see that these are survival curves. Obviously, when you look at CD8 T cell infiltration, the high CD8 T cell infiltration is the red. And then you look in the middle pane, the same thing. There's a significant survival difference in patients that have higher immune signature, higher innate immunity, compared to patients that have lower innate immunity. Even when you throw in HPV, you'll see that even when you stratify by HPV, you see that this still holds true. So patients with HPV positive tumors with high immune activation, they have the best survival. HPV positive tumors with moderate immune infiltrate, you see they still do well. But then you look at HPV negative tumors still with high infiltrate, they actually do even better than HPV positive patients with low immune infiltrate. So, and that's really turns this thing on its head, right? So why do patients that are HPV negative with high immune infiltration do better than patients that are HPV positive with low immune infiltration? I think the proof is right there, and really makes us feel like we need a deeper understanding of what's going on. So just to summarize this portion, there's an increased differential expression of genes related to B and T cell function in HPV-related head and neck cancer. Um, Increased CD8 T cell and CD19-20 B cell density in the tumor microenvironments of HPV-positive patients plays a significant role in prognosis. And high immune infiltrate and B cell signature confers a survival advantage. So how does the tumor play a role in this? So as we've discussed and alluded to earlier, the tumor microenvironment is a highly complex system. It's composed of cancer cells, stromal cells, immune cells, the extracellular matrix, and obviously blood vessels. So these interactions develop during tumor development, help determine the therapeutic response. And while angiogenesis can reduce the hypoxia in the tumor, the partial pressure of oxygen is below 5 millimeters of mercury in most solid tumors. So when you compare this to venous blood, is around 40. So this is truly a hypoxic environment. And this will eventually lead to genetic instability, and this leads to a high number of mutated cells and eventually associates with cancer progression. And when you look at glucose metabolism in mammalian cells, you see that afferent blood delivers glucose and oxygen to tissues where it reaches cells by diffusion. And then eventually goes through glycolysis, which is what's depicted here. That results in the substrate for the Krebs cycle. We're not going to go through this. So this is well known. But what does the Krebs cycle do? Eventually, it produces reducing equivalents for oxidative phosphorylation, which is aerobic respiration, which is how all of us derive energy from substrate. But what's important is this, something called the Warburg effect, which Dr. Warburg won a Nobel Prize for. But on the left, screen left, you'll see that normal metabolism. So in this tissue, the presence of oxygen shunts metabolism into mitochondrial respiration, which is normal aerobic glycolysis. But as you'll see on the right, metabolism in cancer cells is different. So this is characterized by an increase in the rate of glucose uptake and a preferential production of lactate via glycolysis. And this happens even when oxygen is present. So that's a problem, and that leads to several downstream effects, which we'll see. So glycolysis is super ineffective, right? There's only 2 ATP that are generated versus 30 plus in aerobic respiration. So what is the end result of this? Is lactic acidosis. So as we'll see, lactic acidosis in the tumor microenvironment, that results in several bad things. So, and this has been corroborated in several preclinical models. So this was a mouse cancer model. In this study, the authors looked at tumor invasion and peritumoral pH. And so as you'll see at the bottom, that's the distance from the leading edge of the tumor. And on the y-axis, you'll see expression of GLUT1, which is a transporter for glucose into the cell. And you'll see that the leading edge of the tumor has the highest production of GLUT1, which is essentially gets glucose into the cell for anaerobic metabolism. And you'll see this corroborated also with the NHE1, which is a hydrogen transport. So in other words, this ramps up production of lactic acid. And this leads to a tumor microenvironment which is fundamentally acidic. And this really hampers cell function and allows the tumor to adapt and develop mechanisms for propagation and metastasis. Skip this slide for time. So really, there's a gradation. I'm sure all of you have heard of this concept of, dysplasia, mild dysplasia, moderate dysplasia, severe dysplasia, cancer, carcinoma in situ, and then cancer. So we all know about this continuum, but really what happens at a metabolic level? So you have normal epithelial cells in the gray, they become hyperproliferative, that's in the pink. And as they reach the oxygen diffusion limit, they become hypoxic, which is the blue cells. And then they eventually adapt to a glycolytic phenotype, as we talked about, the Warburg effect, which allows these cells to survive and propagate. When they turn to glycolysis, which is obviously much quicker than mitochondrial respiration, the lesions become acidotic, and that just becomes a cycle, right? That eventually selects for the most motile cells, which is yellow, and they eventually breach the basement membrane and allows local, regional, and distant metastasis. So if this is truly a continuum, is it really just cancer, or is it just cells that are having a bad day, right? Is it just cells that are having a bad day, and can we reverse this process? So what we end up with is this constant struggle between um, tumor cells and cytotoxic T cells, which is our body's essentially sentry against cancer. And they're in this constant fight for metabolic superiority. You see that glucose consumption by tumors metabolically restricts T cells. That leads to their dampened glycolytic capacity, and their interferon gamma was one of their effectors. It's a cytokine. And this allows tumors to progress. And in mouse models, we've also seen that ramping up glycolysis in the tumor is sufficient to override innate immunity and the protective ability of T cells. But we've also shown in animal models that checkpoint blockade is, I don't know if you all are familiar, but checkpoint inhibitors are recently approved in the last 10 years for locally advanced metastatic head and neck cancer, and really revolutionized head and neck cancer care. But, and we'll talk about it soon, but PD-L1, what they call PD-L1 antagonists, these permit T cell activity to revert to glycolysis and interferon gamma production. So tumors, they want T cells to not have effector function. Now with PDL checkpoint inhibitors, we can ramp up T cell glycolysis and effector cytokine production. And this resulted in a reversal of essentially a incredible pathologic response. So in other words, it's like Tom and Jerry, right? Where you stop one and by default you increase the other. So this really reveals a plethora of targets that we can act on, and hopefully in the next several years we can make some more strides into understanding head and neck cancer even more fundamentally. So now we know that tumors actively contribute to tumor suppression, but really in head and neck cancer, our patients aren't helping much, and that's what we'll hopefully look at in the next couple of minutes. So there's a complex interplay between T cell and antigen presenting cell. So the T cell activation relies on the T cell receptor, which recognizes antigen, and there's co-stimulatory interactions between these two for appropriate T cell activation. And as you can see, PD-L1 and CTLA-4, those are sort of the most common immunotherapeutic drugs. They're just two of probably hundreds, maybe even thousands of T cell regulatory signaling pathways. So we really just need people that are interested and willing to and motivated to do this work to really have a more fundamental understanding. So there are also other patient factors, right? So one of these is sarcopenia. Sarcopenia is well studied. It's essentially a marker of patient health and muscle health. And this was a study in which the authors reviewed the patients of head and neck cancer treated in a 4-year period at a single institution. And they defined sarcopenia as skeletal muscle area measured on a CT slice at the third cervical vertebrae, just a way for them to sort of enumerate sarcopenia. And they looked at essentially a bunch of factors and found that patients with sarcopenia, if you control for all other factors, have a much worse outcome than patients that don't have sarcopenia. So when you look at a second layer, which is the lymphocyte infiltration or a high lymphocyte monocyte ratio, you'll see that patients with sarcopenia and poor innate immunity do much worse than their counterparts. So this suggests really a crucial role for muscle health in patients' anti-tumor immunity. And it's kind of a busy slide, but it shows everything that muscles do in regulating metabolism and immunity. So muscles are really crucial. They're not only crucial for us to live and move around, but they're crucial as an endocrine organ. They're a true endocrine organ. they secrete myokines, and these myokines crucially regulate a whole bunch of stuff, really important stuff. And so one of those is IL-15. IL-15 is vitally important in the development and maintenance of natural killer cells, which is really our body's way of one of our body's ways of having potent anti-tumor immunity. And there's a bunch of others which I won't belabor the point, but you get the idea. And the same idea here. Aging muscle or muscle that's sarcopenic, this results in impaired myokine release. And this eventually results in immune suppression. And eventually that leads to immune escape of tumor and metastasis and poor outcomes. So not only are head and neck cancer patients notoriously sarcopenic and malnourished, they also smoke. So this was a transcriptomic study of 280 patients with head and neck cancer, and they found that head and neck cancer had the highest levels of CD56 infiltrate, but CD8 T cell infiltrate was low in patients with high smoking signature. And ultimately, tumors with genetic smoking signatures had much lower immune infiltrate, as we've seen earlier, and these were associated with much worse survival compared to their counterparts. So, to summarize, if you have a head and neck cancer patient in your clinic, they have sarcopenia, they smoke, and both of these eventually lead to this perfect storm of impaired anti-tumor immunity. So this creates, again, that perfect storm. So there's been a lot of talk about sort of this exhausted T cell phenotype. So what does that mean exactly? Exhausted T cells lose their effector functions, and they accumulate either due to chronic infection and disease, which results in a sort of a regulatory signature or a immune suppressive phenotype. So how can we use this, or how can we sort of manipulate these things to our advantage? And so this is sort of our call to action, right? So we enter now anti-PD-L1 agents. So these are immune checkpoint inhibitors. So the group that discovered this, one of many, but Dr. Allison at MD Anderson, he won the Nobel Prize for this work. So we know the mechanism of anti-PD-L1 agents, but just to reiterate, on the left you'll see that tumor cells inhibit cytotoxic T cell activation by expressing PD-L1. This in turn leads to T cell suppression. But when you introduce PD-L1 antagonist, it blocks that signaling, and that results in a release of T cell inhibition, which ultimately that results in T cell activation, which results in activated anti-tumor immunity. And like I said earlier, PD-L1 agents are approved for locally recurrent and metastatic disease in head and neck cancer, but recently we've learned that there are some other avenues that we should be exploring their use. And so there's really three ways that we might use checkpoint inhibitors. There's neoadjuvant, which is before any definitive treatment. There's concurrent, which is usually with radiation. And then adjuvant, which is post-definitive treatment. And so we'll address each one in turn. So first we'll start with concurrent. So the standard of care generally for oropharynx and larynx cancer is chemoradiation, and that's well understood. That's based on clinical trial data that's over 20 years old. But the question is, why don't we use immune checkpoint inhibitors with radiation instead of cisplatin, which can be quite toxic? And so this is a summary slide of basically the most important concurrent immune checkpoint studies. Almost all of these studies have been since published with negative results. So Javelin 100, that was negative. Keynote 412, that was negative. Gore-Tex has since been completed, and that was also negative. And so why is that, right? So immune checkpoint inhibitors, they require a competent immune system. With radiation and surgery also, you essentially ablate or destroy the immune system that's available, either the lymphatic structures or the tumor microenvironment that's present in the primary tumor. So you're essentially destroying the things that we need tumor response to happen. Um, this was a randomized double-blind phase 3 study where patients got either avelumab, which is a PD-L1 agent, plus CRT versus standard CRT. You'll see there's no difference. So what does all this mean? That means concurrent, that's not the way we're going to get it done, right? So how about adjuvant? Adjuvant, again, is when we administer PD-L1 agents in a post-definitive setting. And so this is not traditional head and neck cancer, but when we look at melanoma, we see some striking differences. So this was a study from the New England Journal in 2023 where they compared either pembrolizumab, which is a PD-L1 agent, in the neoadjuvant and adjuvant setting versus just the adjuvant setting. And 154 patients were randomized to the treatment group and 159 to the control group. And you can see that the neoadjuvant adjuvant group had a significantly higher EFS when you compare that to the adjuvant only group. And so, in other words, adjuvant, there's a ton of other data that I could show you. You just have to take my word for it. Adjuvant is not the way we're going to get it done. In certain high-risk settings, maybe, but really the way immune checkpoint inhibitors work, we need competent immune system and we need antigen present for it to work. So now we're going to come to the one that I think holds the most promise, and that's the neoadjuvant group. And so why neoadjuvant? Well, there's several reasons why neoadjuvant, I think, is effective. One, like I just mentioned, immune checkpoint inhibitors are much more effective when there's antigen present. Second, we're often waiting to initiate definitive treatment, either due to dental delays or treatment delays, like Dr. Mwala mentioned, or transportation issues, or social health issues. So while we're coordinating care, why not just start some therapy, right? And then the last thing is window trials. So window trials give us this unique opportunity to really understand tumor biology, which we'll talk about in a second. So there have been several phase 2 studies in this space. So this was one study by Dr. Upaluri in which 36 patients with either stage 3 or 4 local regionally advanced head and neck cancer received a one-time dose of neoadjuvant pembrolizumab or 2 doses, and then received standard of care surgery and radiation, etc. And you'll see that there were no serious adverse events. There was no surgery delays, which again makes it clear that this neoadjuvant approach is safe. And then the 1-year relapse rate in high-risk patients was 16%, which is lower than historical data. So over 50% of patients had at least some response, and about half of all of those patients had a major pathologic response. And this was a second mucosal head and neck cancer neoadjuvant study. It was called the Incision study. This was with 32 locally advanced head and neck cancer patients, and they were treated with either 2 doses. They were treated with 2 doses of neoadjuvant immune checkpoint therapy using either nivolumab or nivolumab and ipilimumab. And they found a major pathologic response in almost 40% of patients after the combo immune checkpoint inhibitor therapy. And crucially, in this study as well, they found no patients had surgery delay. There were no serious adverse effects or toxicities. And none of the patients with major pathologic response in this study developed recurrent disease in 2 years post-treatment. So again, this is safe. It's likely effective, but phase 3 data is pending. We're going to skip over this in the interest of time. So what is the way that neoadjuvant therapy may help? So there are several ways that neoadjuvant therapy, I think, will likely be the standard of care soon for locally advanced head and neck cancer. The first thing is that pre-existing anti-tumor immunity is unleashed. So in other words, the activated cytotoxic T cells that are released into circulation due to the immune checkpoint inhibitor therapy is released into circulation, and that deposits into the tumor microenvironment locally. It deposits into the lymph nodes regionally, deposits into distant lymph nodes in the liver and the lungs. So they act as sentries for future such insults. And like I mentioned earlier, when we remove the cancer or we treat the cancer with radiation, you essentially destroy the things that help us or that provide anti-tumor immunity. You destroy the tumor microenvironment. You destroy the regional lymphatics, which again provide that anti-tumor immunity. So with immune checkpoint inhibitor therapy, we prime the immune system and allow it to generate anti-tumor immunity. And so neoadjuvant therapy is here to stay. I don't know if any of you have watched The Matrix, but Neo is kind of a badass. And so neoadjuvant therapy really is here to stay. And again, just another stylistic way to look at this. So when you administer neoadjuvant PD-L1 therapy, that results in an activated and expanded tumor-specific cytotoxic T cell pool. And this results in tumor cell killing and more antigen release, right? These T cells are eventually deposited in the primary tumor, in the lymph nodes. This results in potent local regional responses. They're also deposited distantly in the liver, in the lungs, and this eventually results in activity against occult distant metastasis, which is probably why you see a lower rate of distant failure in patients that have had neoadjuvant therapy in those phase 2 trials. So when we try this approach, this neoadjuvant approach, there are several benefits, and one of them is biomarkers of response, right? So what are the characteristics of patients that respond? There's blood and serum markers, there's circulating tumor DNA, there's RECIST, which is basically a radiographic way that we can characterize tumor response. And then what are the immune suppressive mechanisms that prevent response, right? How do we assess the non-responders? And is there anything we can do to flip that switch in non-responders? And then you get to see this very complex interplay between tumor, lymph nodes, and circulating lymphocytes. And this is just a slide of all the ongoing neoadjuvant studies. Actually, there's several more now, which I haven't included. But this is really going to be the big one. This is Keynote 689. It's a Merck study by Dr. Upaluri at Harvard, who's the primary investigator. This is the first phase 3 study of neoadjuvant and adjuvant Keytruda combined with standard of care in patients with resectable stage 3 and 4 mucosal head and neck cancer. And so this is the schema. The patients are randomized to either neoadjuvant or standard of care therapy, neoadjuvant plus standard of care or standard of care. And the patients then undergo surgery and then either adjuvant pembrolizumab or standard of care, and then are followed for disease evaluation, safety, and survival. So this trial is actually going to read out in the next several months. There was already a first interim analysis, and the neoadjuvant adjuvant group had a better EFS. Obviously, there's still too soon to comment on overall survival and disease-specific survival, but there was a better EFS in the neoadjuvant adjuvant group. So more to come on this very soon, and we'll just have to stay tuned. So here at the LSU Department of ENT, we've got several studies ongoing that are in this vein. One of them is NRG HN014, which is a cooperative group trial led by Dr. Gross at MD Anderson. This is a neoadjuvant anti-PD-L1 for advanced cutaneous head and neck cancer. A lot of this we've seen in cutaneous head and neck cancer as well. So that trial is open and accruing at our institution. The second is a tumor bank. We have an ongoing collaboration with the LSU Department of Kinesiology and a very talented tumor immunologist there by the name of Dr. Spielman. We're characterizing blood and tumor immunophenotypes, and much more to come on this. And then we have an active collaboration as well with the Department of Environmental Science, Dr. Mukhopadhyay, who's big in the artificial intelligence space. We're using AI and a deep learning model to understand poor immunophenotypes for poor clinical prognosticators, as well as predictors of poor surgical outcomes in our head and neck cancer patients. So a lot more to come on this, and we're looking for collaborators. So if you're interested, please reach out. So just to summarize, there's been a lot of work um, with immune checkpoint inhibitors. We've also obviously have a long way to go. So, like I mentioned earlier, there's really a lot of well-intentioned people that want to do good work, and really it's our onus to bear. We treat these patients; they have very difficult problems, and there's a lot of targets that we may have. One of them being metabolic reprogramming, like we talked about. Um, is there a way that we can affect tumor metabolism? Is there a way that we can reduce tumor reliance on glycolysis? Is there a way we can decrease glycolytic pathways in tumors? And then the second is immune reprogramming. Is there a way for us to stimulate myokine production? Is there a way for us to activate T cell metabolism and T cell glucose uptake? Is it all of these? Is it none of these? Right? And so that's my challenge to myself and everyone here. We really have a golden opportunity to change cancer care. This is a defining moment in sort of the timeline of head and neck cancer. And it's really our cross to bear, and we're ready to do the work, and we're excited to do the work. And so just to summarize, immune infiltrate really predicts clinical outcomes in head and neck cancer. Characteristic tumor metabolism results in alterations in the tumor microenvironment. And like we talked about, sarcopenia predicts immune senescence and reduced anti-tumor immunity. And there's really targets everywhere, so it's time to get to work. So I appreciate it.